I am Srini Adakalon. I'm the chairman of the scientific committee of Kerala Society of Ophthalmic Surgeons. Prashop, please take over. Thank you, Dr. Srini. First of all, a hearty welcome to Professor Dua, Professor Harminder Singh Dua from Nottingham. It has been a great honor to have you on our platform. Sir, you will be addressing a hall full of delegates. Unfortunately, you can't see them, but they are watching you on the screen. And this is the annual conference of the Kerala Society of Ophthalmic Surgeons, Drishti 2022. We have with us as moderators Dr. Sridevi Nair, and I think Dr. Mallikarjun will also be joining us soon, along with Dr. Sujit Nayanar. And it's a great honor to have you here, sir. First of all, I'll start off with a small introduction. He needs no introduction, but still, I think there are things which we must know about Professor Dua. The list of achievements is just staggering. It will take half an hour for me to read the whole thing, and not even half an hour, probably an hour. So he's currently the chair and professor of ophthalmology at the University of Nottingham, and is the head of the Division of Ophthalmology and Visual Sciences. Previously he used to be the associate professor at Thomas Jefferson University, Philadelphia, USA. And he did his MBBS from Government Medical College and Hospital in Nagpur. Right now he has his own private practice as well, called Dua Medical at Nottingham. And he has taught several generations of ophthalmologists, all of whom are doing really well, many of whom are professors. His corneal surgery course at the Royal College of Ophthalmology is fully subscribed every year. He has countless papers. His notable discoveries and inventions, which we know are the fine needle diathermy for blood vessels in the cornea, for the SSCE, the sequential sectoral conjunctival epithelectomy, the alcohol delamination for recurrent erosions, and of course, the most famous Dua's layer, which is a key finding that has revolutionized corneal surgery. And he's currently he has been the president of the Royal College of Ophthalmologists in the UK. He's the first chair of the Clinical Council for Eye Health Commissioning, England, editor-in-chief of British Journal of. He was the editor-in-chief of British Journal of Ophthalmology. Was the president of the EVER, the president of Eucornea, one of the founding members of Eucornea, part of the International Steering Committee of DUTES 2. Immediate past master of the Oxford Ophthalmological Congress, currently the editor of the Eucornea. He's a civilian consultant advisor to the Royal Air Force and president of EVER. He has over 125 international awards, and one of them, a notable one, being the commander of the most excellent order of the British Empire for his services to eye healthcare, health education, and to ophthalmology in the Queen's Birthday Honours in 2019. So I'm not going further into the details. You all know Professor Dua himself. You're all waiting with bated breath to hear from him. So Professor Dua, please go ahead.
Well, thank you very much for that very generous introduction. And good evening to all of you. It should have been a very good morning from Nottingham, but I'm very sorry. I sincerely apologize for the mix-up and not being there at 8 o'clock where I should have been, and I'm grateful for you to rearrange it for this afternoon. So I'm going to share my screen and take you through some of the aspects of corneal pathology that have come to light after the discovery of the layer and the understanding of the posterior corneal anatomy. And you will be surprised to see how, as they say, the eye cannot see what the mind doesn't know. And once the mind knows, we start seeing things which were always there. So understanding the corneal anatomy, and excuse that spelling mistake there, especially posterior corneal anatomy in the context of the predesperate layer.
Can you share your screen, sir?
I've sort of shared, have I not shared it?
No.
So sorry.
Yeah, it's
visible. Is it there now?
Yeah, it's visible. You can make it full screen and.
Okay.
Yeah, it's okay now.
So once again, I'm sorry. So I was saying, as you probably heard me, this was the first slide on the title, and understanding corneal anatomy, especially posterior corneal anatomy in the context of the predestined layer, has led to novel insights on various diseases of the cornea. So there are three basic things that I would like to emphasize first, three comments on posterior corneal anatomy. Oh dear. Let's see. Yes. So the first one is that the optical coherence tomography shows the Descemet's membrane as a double contour line. A lot of times people make the mistake in interpreting OCT as histology, which it often correlates to, but is not. It represents differences in refractive index between two media of two tissues. So here you see the aqueous and the anterior surface of the Descemet's membrane as a bright line, then the thickness of the Descemet's membrane as a dark shadow in between, and where the light exits from the posterior surface or endothelium and into the aqueous, there's another difference in refractive index, which gives you the double contour line. And here again, you can see this is a paper with ultra high resolution OCT. The two lines are both Descemet's membrane. The last row of keratocytes identified by the red arrows, and in between is the predescemet's layer, as was described by Beziva et al. From Canada. So this corresponds with the corneal histology, as we see over here, with the predescemet's layer being where my arrow is now, the Descemet's and endothelium posterior to that. Now, we all know about the three big types of big bubbles. The first type was the type 1, where air injected in the stroma causes a central bubble, which is about 8.5 millimeters in diameter. And it does not extend all the way to the periphery because the predescemet's layer is very thick and attached, well, very densely attached to the thicker stroma at the periphery. That contrasts with the type 2 bubble, where the air actually enters anterior to the Descemet's membrane and forms a very thin wall bubble covering the entire posterior surface of the cornea. Excuse me. So the type 1 is elevating the predescemet's layer and the Descemet's membrane, whereas the type 2 is elevating the Descemet's membrane only. So that, moving on to the mixed, where you have type 1s and type 2 together, and you can see here a very nice central type 1 with a crescent of the type 2 at the periphery. And here's a large central type 1 with a big horseshoe type 2 at the periphery. So you've got both the bubbles together. And when you take off the Descemet's membrane of any of these types of bubbles, whether it's type 1, type 2, or mixed, you see that Descemet's membrane is always intact. You have the banded, non-banded zones and the endothelial cells. And the third point I want to make before going on to the pathology is that in a type 1 bubble, when the bubble is being created and the predescemet's layer is being separated along this cleavage plane from the posterior stroma, you see these strands of collagen extending from the posterior stroma to the predescemet's layer, and it'll strip off along this last row of keratocytes, and you see these strands. Surgically, sometimes when your bubble does not correspond to the center of the cornea, or your trifine is not corresponding to the center, a little part of the edge of the bubble does not separate, and you have to physically dissect or cut these strands that are extending, and they're much more prominent at the periphery of the bubble, but they're fine strands that actually give way as the bubble forms. And that is what helps us tell a type 1 bubble, where you get this rough appearance on the surface, compared to a type 2 bubble, which is absolutely homogeneous appearance of the anterior surface of the Descemet's membrane. Here you're seeing the anterior surface of the predescemet's layer. So with these in mind, let's look at some pathology. Samuels was the first one to describe Descemet's membrane detachment almost 100 years ago. And the definition was detachment of the Descemet's membrane, which has prevailed through all these years. And the most recent definition, again, in the Survey of Ophthalmology 2020, uses the same term, detachment of the Descemet's membrane. Now, I will show you that on the basis of the pre-Descemet's layer as part of the microanatomy of the posterior cornea, the Descemet's membrane detachment is not what we have thought it to be for almost 100 years. And this work has been published. And in summary, just like you get the type 1, the type 2, and mixed bubbles, you have exactly a type 1, a type 2, and mixed Descemet's membrane detachments. When you see a detachment which is a straight line, like a chord of a circle, it is made up of the pre-Descemet's layer and the Descemet's membrane. When you see a wavy kind of a Descemet's membrane detachment and the double contour line is more obvious, then it is a type 2 kind of Descemet's membrane detachment corresponding to the type 2 bubble. And what is interesting, you see here, you see that straight line, and you also see that wavy line. And these are all from patients from across India and the UK, and one from South Africa, because a lot of the authors on this paper were from India who contributed these images. So not only here have the pre-Descemet's layer and Descemet's membrane detached from the posterior cornea, but they've also separated from each other, just as would happen with the mixed bubble. Now, the type 2 detachment, we know, can tear, sometimes the Descemet's membrane tear and scrolls with the endothelial cells outside, when we would use the term rhegmatogenous Descemet's membrane detachment. Now, here's a patient who had chronic corneal edema following cataract surgery. And what you see on the slit lamp is a straight line taut like the chord of a circle on OCT, straight line. That is a type 1 detachment where the pre-Descemet's layer has also spontaneously detached. No air or visco or anything was injected in this eye. That's how they present. Here are some examples, and we've done histology in 5 cases. So an eccentric graft had a detachment, sorry about this. And you can see there was a straight line. We did a PK, and then we were able to show that the endothelium with the Descemet's membrane was posterior. And you see that pre-Descemet's layer, which here is completely acellular. There are cells on its surface, but the layer itself does not have any keratocytes in it. And OCT showed that straight type of detachment. So there's evidence histologically to show the pre-Descemet's layer separates. Here you can see there's a straight line, but there's a torn Descemet's membrane which has curled. And here you can see 2 straight lines. The anterior one more straighter, the posterior one more wavy. So that's a mixed detachment. And what is interesting here is that occasionally you will see this strand extending from the posterior surface of the cornea to the anterior surface of the detachment. And if you see that strand, you know 100% that this is a type 1 detachment, because you don't see a strand between the posterior surface of the pre-Descemet's layer and the Descemet's membrane. Now, this was another patient where on histopathology, we could show the pre-Descemet's layer had detached. But what is interesting, this was a failed graft of long standing, that the stroma was populated by a lot of keratocytes. So what happens is that the keratocytes produce fibroblasts, myofibroblasts, lay down collagen and cause shrinkage and tightness of this tissue, so that it is very difficult to put back. So it has a lot of therapeutic implications. Type 2 detachments, Descemet's membrane only, even if they're torn and scrolled, you can inject air, unscroll it, and you can put it back. But the type 1 detachments, particularly if they are long-standing, you will find that it will go back up, it will attach, but as soon as the air is absorbed, it will bounce back. And there's even been a case where it's so taut that you can see the bubble is being compressed backwards, and bubble appears like a D shape because it can't push this layer back on. So very useful, and one might consider doing a desmetectomy to release the tension or an endothelial keratoplasty. And here's another example where the patient had, after cataract corneal edema, so the periphery of the corneal edema, you could see the type 1 detachment. As you move toward the center, you can see two lines, one wavy, one straight. And then right at the center, one could see the type 1 component as a straight line, and the type 2 component had actually torn and scrolled. So there was a mixed detachment, but the type 2 component, the desmus membrane, was also torn, making it a regmatogenous mixed detachment. This was a case we shared kindly with Sangeeta Wagh, who you probably all know, and the patient of very severe peripheral ulcerative keratitis who presented with a straight line detachment. And then on OCT, you can see, you can see that detachment straight line. OCT, it was classic of a type 1 detachment, but there must have been a tiny hole or tear in it somewhere, because over time the edema cleared. The endothelial cells might have migrated through, repopulated the posterior surface of the cornea, and then it cleared. So they were thinking and contemplating a endothelial keratoplasty procedure, but because the cornea cleared and specular showed some endothelial cells, as you can see here on the posterior surface of this cornea, even though there was a type 1 detachment, they left that in place and were able to do a cataract operation for this patient. So we will now see this very often, and OCT will be really very useful, but that clinical clue is there. If it's a straight line, most likely it is a type 1 detachment. Now, what about corneal infections? Deep fungal abscess and intracorneal hypopyon. OCT images show that there is collection of debris and pus in the interface. So this was first reported by Liu et al. Just 1 year after we had published our first report on the predesmate layer, and they showed that this layer offers a preferential plane for the fungal elements to migrate and separate at the back. And we have now seen this anecdotally in 3 of our patients who were proven fungal cultures. And I'm sure with the number of fungal cases you have, you will see this much more often. If you do OCT in a patient like this, in fact, do OCT on all your infective keratitis patients, some of them will have this predesmate layer detachment with inflammatory debris, as you see over here. And these, the current hypothesis is, are more likely to be fungal in origin, but that still needs to be proven. And the more cases we do, and the more we can correlate this appearance with fungus, then we have a clinical way of at least predicting the likelihood of this being fungal. And it's clearly a project. I've just set this up with a group in King Khalid Eye Hospital in Saudi Arabia, where I was yesterday. But clearly anybody here in the audience wishing to collaborate on this, be more than welcome. Or you can just do it yourself and write a paper yourself to show that this is or isn't the case. The same is true for intracorneal hypopyons. Intracorneal hypopyon, you can see the edge of this hypopyon here, where the limbus is here, and corresponds more or less to the diameter of a type 1 bubble. And that's where the pus has accumulated. So again, telling us that the reason for this is the cleavage occurring between the predesmate layer and the posterior stroma. And there's another patient here with Agrawal's group. This is the OCT image, you can see the pus is over here, and the top part is clear fluid as all the cells settle. And there's what would appear to be like a type 1 detachment. So our understanding of some of these things which we've been watching all the time is now a little more clear as to why that might be occurring. So this patient has a hypopyon over here and also had an intracorneal hypopyon. Yeah, so if you straighten that OCT, that's how it will appear, like a vertical fluid gravitating to the bottom. Infectious crystalline keratopathy is the migration of bacteria in the corneal stroma. in the absence of the host response. And it gives you this Christmas tree or this branching pattern. If when you inject air in the corneal stroma to create a bubble, we see exactly that same pattern of a Christmas tree branching. And it tells you that it is the lamellae of the corneal stroma which determine this appearance, rather than the biofilm or the species of the bacteria, which you will find is often quoted in the literature. So we had done a little experiment in the past. If you take eye bank corneas and you turgis them, don't deturgis them, let them be swollen, and you inject bacteria, in this case, staphylococci bacteria, or we even did it with streptococci and with Canthamoeba and others, they grow as clumps. But if you deturgis the cornea by putting it in dextran medium, make it more compact, and then inject the same bacteria, they grow as these Christmas tree patterns. So it's the anatomy which is determining the pathology, rather than, as is, like I said, the bacteria species or their biofilms. And here you can see on histology, these are the sort of a very low power view of the bacterial spokes as they cause the Christmas tree pattern. Now, let's look at another very, very important condition, acute hydrops. It's been defined as an uncommon complication of corneal ectatic disorders, involves sudden onset of corneal edema due to a rupture in the Descemet's membrane and can cause impaired vision and eye pain. Now, we postulated in our 2013 paper, which was the first one where we told about the layer, and subsequently in an expert review in Ophthalmic 2015, we showed some anecdotal evidence of the fact that the acute hydrops is due to a rupture in the Descemet's membrane and the pre-Descemet's layer, not just the Descemet's membrane. And this was the picture. This is in that expert review in ophthalmology paper where there was evidence to show pre-Descemet's layer was also scrolled over there, and distal to that tear in the pre-Descemet's layer and Descemet's membrane was a fold, which also involved the pre-Descemet's layer. So these were the first images. Now, if you do OCT in all your acute hydrops patients, you will find it will be different. At the periphery, it might be type 1. Towards the center, it might be mixed. But as you reach the tear, you will see that there are two layers, and they are separated from each other, or they may not be separated from each other, but the tear involves both of them. And you get these big fluid lacunae in the corneal stroma. Here's another example where you can see this was acute hydrops in pellucid, and I showed you this picture of the strand earlier, and you can see the two layers are separated in the form of a mixed detachment at the edge of the hydrops. Based on this, Professor Murain from France said, well, I can actually, why can't I treat acute hydrops by approximating the torn edges of the pre-Descemet's layer without approximating the curled edges and torn edges that might be there of the Descemet's membrane. So he injected air, marked the ends of the tear, and put mattress sutures to approximate them. And then he, on the basis, he said, to quote his paper, the fact that the pre-Descemet sutures can also be effective could be explained by the existence of the Dua's layer. Acute corneal hydrops could be due to a tear in Dua's layer. As a consequence, pre-Descemet sutures could reattach the edges of the Dua's layer tear. And this was a paper they published in 2015. Now, this is a very interesting part. I mean, we've all heard of Gerrit Mellis, who's the guru of endothelial, or rather of lamellar corneal transplant. He sort of revived deep anterior lamellar keratoplasty and endothelial keratoplasty. Initially, he was very skeptical about the layer, but then he published this paper, Descemet's membrane detachment in keratoconus does not occur due to tear in, the acute hydrops does not occur due to tear in the Descemet's alone. And the paper was entitled, Are Descemet's membrane ruptures the root cause of corneal hydrops in keratoconus eyes? And what he had done was an accident in nature, or if you want to call it that. He was doing Bowman's membrane transplant in keratoconus eyes, and they were creating a pocket to put the Bowman's membrane. And in some of the patients, they had Descemet's membrane detachment and Descemet's membrane tears. And these patients did not develop acute hydrops. But in those patients, when they were creating that pocket and they were very thin corneas, they inadvertently perforated posteriorly through the pre-Descemet's layer and the descemet membrane, they got acute hydrops. So they concluded, and to be fair to them, they did reference our previous two papers that we said it before on anecdotal evidence that this is what causes acute hydrops near the tear in both the layers. And on that basis, what I had done an experiment where we taken human eye bank eyes, and then you made a slit in the back through descemet and pre-descemet layer for about 180 to 100 microns. Then you turn them round and mount them on artificial anterior chamber, and you can even push the pressure up to about 60 or 80 millimeters of mercury. And guess what? There was no hydrops. So the answer is acute hydrops results from a tear in descemet membrane and the pre-descemet layer in the context of the abnormal collagen and proteoglycan matrix of keratoconus corneas, not in any cornea. And we know that in keratoconus, the whole cornea stroma is abnormal, right up to the Bowman zone and the basement membrane of the epithelium. So we then wrote a letter to them saying exactly that. Acute hydrops is due to tear, and the background of the abnormal corneal collagen and proteoglycans is also important. And then they wrote back quoting us and saying, we thoroughly agree with the primary point of the letter, namely that this is the case. And they were quite complimentary in saying, we're gratified to see our recent article has generated so much interest, particularly from some of the foremost thinkers in the field of the posterior cornea. So it is now an accepted fact that it is both layers that need to be torn, although we have been taught and have taught hundreds of our students that acute hydrops is due to tear in the descemet membrane, but it's not anymore because we know that's the fact. And what about keratoconus itself? But it's a very, very multifactorial, very complex condition. We're just going to make one more point, that it's the degradation of elastin in the pre-descemet layer which is associated with keratoconus, and this might be a significant component of the etiopathogenesis. Now, Keith Meek, by using a technique called on-phase scanning electron microscopy, has shown that between the last keratocytes, which is in purple, and the descemet membrane, which is in blue, there are a lot of these yellow lines which represent elastin. So the pre-descemet layer, they showed, has more elastin than any other part of the cornea. But in keratoconus, all that elastin disappears, and there's hardly any elastin, and the pre-descemet layer basically is disintegrating. Now, we were able to do some elastin stain, and believe me, this took 2 years of trying to get this elastin immunohistology working. If you look at the isolated pre-descemet layer, there is elastin across it through the entire surface of the pre-descemet layer, entire thickness of the pre-descemet layer. But this was not known before, and this is very interesting, that the descemet membrane shows elastin as a band only on its anterior surface, probably corresponding to the banded layer. The rest of the descemet membrane has very little elastin. This is PDEC tissue, so the pre-descemet layer, the anterior band of the descemet membrane, and here you can see partially the pre-descemet layer peeled off, so you can see that's the descemet membrane, that's the pre-descemet layer. And if you take a whole cornea, these were isolated tissues, but if you take a whole cornea and you section it, that's the stroma. You can see clearly the pre-descemet layer. This was first evidence of it being so structurally different from the rest of the cornea, not just in appearance, more elastin than anywhere else. The interfacial matrix is the dark zone, and then the anterior band of the descemet membrane. Now, this is also interesting in this context, and this is just a little sideshow. We know that descemet membrane scrolls very tightly with the endothelial cells outside, and if you put this descemet membrane in a petri dish and add some elastase enzyme to it, over time, spontaneously, the roll unfolds and becomes flat like this. And when you section this, you can see the band is completely degraded compared to a control where the band is intact. And we also went, because the theory then was that this curls outward because of the swollen endothelial cells. And if you do disc-based treatment and take away the endothelial cell, put an F mark, you can see it will still scroll the same way. So it has nothing to do with the endothelial cells, but that is the published and written in textbook explanation for why the descemet membrane scrolls with the endothelial cells outside. But the exact reason is this anterior band of elastin. And you can see over here, this is the same two pictures over there. And if you look at the human cornea, this is normal. You can see that band is a very low power, but in keratoconus eyes, the elastin is completely gone. So we've got this paper just waiting to be written up. Now we've done all the work to show that elastin, it disappears in the posterior cornea in keratoconus eyes, but we were only using very advanced keratoconus where we were able to do PKs. This is the explanation I give. So if you imagine this is the rubber band is the pre-Descemet's layer. It will be very elastic. It has a lot of elastin throughout its thickness. Now, if you pull it and you blow air, it will go down. And as soon as you release the top stroma, the whole thing comes back up. Now, imagine if you put glue on this and make this the anterior band of the Descemet's membrane, and you stick it to a strip of paper, excuse me, and make this the anterior band. And and that paper is the Descemet's membrane. Now you release this. Take your fingers away, and you'll see the whole strip of paper will curl with the posterior surface outside, which is the endothelial surface. And that's what causes this to form the scroll. But it's not there so that we can do DMEC. There must be a physiological role for this. And I think the physiological role is this: because the Descemet's membrane wants to scroll in this direction, as the arrows show, and it is therefore strongly opposed to the posterior surface of the cornea. There is no physical connection, there's just interfacial matrix. And if the Descemet's membrane is constantly trying to do this, it will stay opposed without physical connections, so that when you squeeze the eye, you rub your eye with your heartbeat, with your respiration, when the cornea moves, there is very little tangential traction on the Descemet's membrane, which would otherwise cause more cells to be lost. So I think that's the physiological role. Just to finish off with a couple of other things, descemetocele. Again, if you do OCT, you will find many of them are not just Descemet's membrane. Exactly like in the bubbles, except you don't get mixed, you get a type 1 descemetocele, which is with the pre-Descemet's layer and the Descemet's membrane. You get a type 2, which is the classical descemetocele, and you get a type 3, where you get the descemetocele, the pre-Descemet's layer, and a bit of stroma. You get all these different kinds. They're not just one type. And this montage, which very kindly Dr. Muralidhar Ramappa from the LVPI has shared with me, shows these types. So that would be a Descemet's membrane only. And there you can see there's a Descemet's membrane with PDL and some extra stroma. And in some places, it's only with the pre-Descemet's layer. So we are learning more and more about things we took for granted for all these years. There was this lady from Warsaw who sent me these pictures very early on, said, this convinced me that there is the pre-Descemet's layer. And there was a patient with a silver nitrate injury who they had to do a PK. And the silver nitrate had stained all the keratocytes and the stroma brown. But apart from the last row of keratocytes and the in between the two, there was an area that did not show staining at all. And that corresponded to the pre-Descemet's layer. So morphologically, it became more obvious when there was this kind of an injury. If you look at lattice dystrophy, granular dystrophy, and macular dystrophy, in macular dystrophy, the layer is much more involved and more commonly involved than in the other two. And in these two, lattice and granular, it gets involved very late in the disease and sometimes not. But with the macula, it's more often involved because macular dystrophy is believed to be a problem with the endothelium. And we know that the endothelium, right from embryology onwards, does influence the pre-Descemet's layer quite a bit. So it's more likely that anything that affects the endothelium would affect the pre-Descemet's layer as well. And this final observation or a report published by Walter Lisch, who is the father of dystrophies today, he described Lewis's syndrome, which is biclonal gammopathy with paraproteinemic keratopathy, and there's also increased copper levels in the serum. and they describe a central discoid yellowish brownish discoloration in the pre-Descemet's layer, as you can see here on the slit beam. It's quite deep. So this layer can be preferentially affected in certain types of corneal pathology. I'm not going to go into detail into this last picture, but what you see here is that, as we published many years ago, the Descemet's membrane ends here, but the pre-Descemet's layer carries on. As you see over here, the pre-Descemet's layer carries on and then opens out to form the beams of the trabecular meshwork. On the scanning EM, you can see over here the pre-Descemet's layer, the endothelium has been removed, the Descemet's has been removed, but you can see that this layer imperceptibly merges with the beams of the trabecular meshwork. So the collagen core, and now we know the elastin, that are the key components of the trabecular beams, are exactly the same as they are in the pre-Descemet's layer. So there is this relationship between the pre-Descemet's layer and the trabecular meshwork. We know that following penetrating keratoplasty, the incidence of glaucoma is much more higher than can be explained by the use of steroids alone. And we also know that in dark, where you get, they haven't distinguished between type 1 and type 2 bubbles, but the incidence of glaucoma is less than after PK. So there must be a role, the pre-Descemet's layer, which is not cut in dark and cut in PK, will have to play in maintenance of pressure and in glaucoma. So with regard to pathology, the layer and its understanding has improved our understanding of Descemet's membrane detachment, acute hydrops, keratoconus, spread of microbial infection, desmetocele, intracorneal hypopion's, and other conditions. It could possibly play a role in IOP maintenance and glaucoma, and more has yet to come. Thank you very much.
Thank you, Professor Dua, for that wonderful presentation. It's fascinating how your discoveries and how corneal microanatomy is influencing pathology, and how this is going to influence how we teach our postgraduates in the future. Now, I think we have the forum open for questions. I'll start with a question of my own. I'm a corneal surgeon and I do a lot of diets. And I've seen that the phenomenon that you mentioned, where the pre-Descemet's layer is attached to the stroma in the periphery, quite strongly, and you had to cut it with the scissors in that video that you showed. Can that attachment be there in the central cornea as well, in certain corneas? Because in certain types of corneas, certain keratoconic eyes, I've seen that the Dua's layer does not, the type 1 bubble does not propagate towards the periphery. That's question number one. And the other question is there any technique which you could adopt to get more type 1 bubbles and prevent type 2 and type 3 bubbles from forming?
Yeah, so the first question is that the more advanced the keratoconus, the more likely you are to get adhesions between the pre-Descemet's layer and the posterior stroma. And particularly if there's acute hydrops, I never attempt the bubble technique if there is acute hydrops that has resolved. Invariably, it will tear. So you can do it mechanically, but you then have to leave behind some of that scar tissue. And if it's in the visual axis, there could be problems with the final outcome. In scars that are secondary to infectious keratitis, again, depending on how deep the scar are, you're more likely to get a type 2 than a type 1 bubble because of those adhesions. And remember, this structure it's a dynamic structure, the pre-Descemet's layer. It will respond to injury, it will respond to inflammation, and it changes in thickness over time. And there's a 1979 paper by John Marshall, which he has looked at various aspects of the corneal anatomy with electron microscopy, and it showed that the Descemet's membrane increases in thickness from a 20-week-old fetus to an 80-plus-year-old patient. It does increase in the Descemet's membrane. Now, he mentioned nothing else, but there it was so obvious. You go back and look at his pictures, you can see the PDL very clearly with the last row of keratocytes anterior. in all the pictures, there's not a single cell in it, but that has also increased in thickness with age. So it is changing. And naturally, if it responds to inflammation and becomes cellularized, and there is abnormal fibrous tissue in it, then it will behave differently. So that might be a reason why we see this, that it doesn't always form a complete type 1 bubble. But the second question is more difficult to answer. We are working on it. There is no technique now and no tip that will guarantee a type 1 bubble all the time. The only thing that we know works is that the deeper you are in the stroma when you're injecting air, the more likely you are to get a type 1 bubble. If you are more at the periphery, and there's a complete different story to tell as to why a type 2 bubble usually starts at the periphery. So there are these fenestrations in the predesmate layer as it opens up to form the trabecular meshwork. And if air enters one of those, because the predesmate layer itself is impervious to air, otherwise we would never get a bubble if air went through it. So it doesn't let air to go and it forms. But at the periphery, there are holes. And if air enters that, then it will go straight in the cleavage plane between desmus and predesmus and give you a type 2 bubble. So you got to go deeper. And one of the tricks is that when you make, the way I do it is I go to deep lamellar depth with the Trifine, and then I inject such that I am deeper than my depth of the cut. So that when the air comes out, so that a lot of it escapes through the wound. So you have to use a little more force, be more rapid, and go deep. And that is the only tip I can give you, but it's not guaranteed. And someday we'll work out how to do it.
Great. The other question I wanted to ask was, you described the use of elastase to prevent the scrolling of the desmus. Have you looked at whether it affects the endothelial count? Does it?
Yes, that's $1 million question. We are working on it, but you can imagine so any enzyme has concentration, temperature, and duration, 3 key elements in its activity. So you got to get the right temperature of the medium for the right duration, whether it's seconds or minutes, and the right concentration of the enzyme that does not affect the endothelium and also does not permanently damage the predesmate layer. You want the elastin fibers to slightly slacken, but not to be able to rebuild. So that you give that window of opportunity where they're slackened enough for you to open the desmus membrane, and then it recovers and it's back where it should be. Now, if you can, then we could do DMEC with eyes of any age. But until we do that, we keep doing PDEC, because PDEC you can do with even an infant eye, and at any age, which with DMEC is difficult. Now, what we found is with DMEC, you can peel off, even with, between 40 and 50 years, you can peel the desmus off. But you're asking for big trouble, because that's when the problem starts. It is so tight, the roll, and so thin. To open it in the eye is a big challenge. And then it's probably not worth trying, because then you lose the membrane, it comes out through one of the ports, and so on. So the younger donors, we will be able to use for DMEC if this works out.
Yeah. Thank you, sir. Any questions from Dr. Sridevi or Dr. Mallikarjun?
Good evening, sir. I have one question, sir.
Sure.
So we have this one relatively rare complication during LASIK, femtosecond LASIK, where we see the formation of intracameral air bubble formation. So would you think that, is it possible that as opposed to the currently accepted theory that the air bubble migrates through the Schenck's canal and the trabecular meshwork into the anterior chamber, could they be migrating directly from the stroma through the fenestrations in the peripheral PDL into the anterior chamber, which is why we only see it in some cases of LASIK and not all? Is that a possibility?
Yeah, it is to be 100% proven, but if you look at any operation in which air goes into the anterior chamber, and the commonest is the big bubble technique of Dow.
Right.
You get air in the anterior chamber so often. And just like with LASIK, it has been propose that it is due to air going through the trabecular mesh.
Yeah.
Now, the air will, if you are injecting, just try to visualize, okay? Air bubbles are being produced at the site of the energy that is being deposited in the corneal stroma. Now, to enter the anterior chamber, you either need a fenestration through and through, somebody's perforated, which doesn't happen in LASIK nor in dark most of the times. But if this air moves to the periphery, right, how will it get into Schlem's canal without first being in the AC? We say things because people say, but if you stop to think about it, this air will be anterior to or peripheral to your Schlem's canal. And the Schlem's canal, the only connections is the collecting channels which open into the aqueous veins and into the ophthalmic veins. So how is air going to get from outside into Schlem's canal to get into the trabecular meshwork?
Yes.
There's no way.
Yes.
But it can get from the trabecular meshwork into Schlem's canal, but it has to get in the eye first to do that route. Right? So the other explanation is that it's not really the Schlem's canal, but it is air which forces its way into the trabecular meshwork. And from the trabecular meshwork, then it filters out or reverse direction into the anterior chamber. So one can't build the canal in the pathway. It's mostly the meshwork. So if the air is getting into the meshwork, it will do that. Now, if you look at the number of times this happens in the dark operation, and it can be quite a lot of air. This air is under a lot of force. It will actually rip the meshwork apart. It will cause damage, you know, and air can cause a huge amount of damage if you force it into any tissue. And one would therefore expect some issues with the pressure in these eyes post-dark, where there's air in the anterior chamber. And we don't. We in fact see less. Maybe it's less, it's not low pressure, but the incidence of high pressure is less than after PK, as I mentioned. So it's not clear yet what route it has been taken. But if you look at these fenestrations that we have observed, and they are right under where a type 2 bubble starts. So you mark the point where a type 2 starts. These are in human eyes. And then you peel off the desmids and you do scanning and you see these holes. So maybe there are these fenestrations which are allowing the air to go. So it's a moot point. I mean, it's not the meshwork, not the canal, but just more central to it where these holes are located.
Thank you, sir.
Dr. Mallikarjun, anybody else want to ask any questions?
It's a very basic question. And see the way the predestined layer, you call it as a predestined layer, but we all, whole world, and we all call it a Dua's layer, sir. I don't know, in your presentation, you always mention it as a PDL. I won't answer for that also, but histopathologically, is it how does it differ, sir? Because it is entirely different from other stromal layer. So
yes, so very good question. You know, we are about almost 8 months ago, we wrote a major review article for progress in retina and eye research on this on this layer and all its implications, including pathology, some biomechanics, and so forth. And we've got, as it is, mixed review. One said accept, the other said some question, the third says everything is negative. And one of these comments in the controversy is the name. You know, why is it Dua's layer? But nobody will say, why do we have Bowmans and Desmis, but we can't have Dua's? And for me, that sort of detracted from the original discovery. The people started questioning the name rather than what we were describing. And when we got that criticism in the press, and I told all my colleagues, and other members of the team that we should call it the pre-Descemet's layer, not Dua's layer. So one of them said, okay, but when the dust settles, PDL will be Prof. Dua's layer anyway. so that's the name, that's the reason why we said, but anyway, you're right. In fact, many textbooks and many keywords of publications have used the term Dua's layer. And my Professor John Forrester, who writes the book, The Eye and Basic Sciences, his most recent edition, he has a section on this, and he just calls it Dua's layer, and not, he said, no, I'm not going to call it anything else. And is there. So there is that bit about the name. So how is it different? And there are more and more ways we are looking at it, apart from those that we publish. So if you look at the posterior corner, so this is layers about, say, 20 microns maximum, between 8 and 20. So if you look at the corresponding part of the stroma anterior to it and compare it with the layer, right? What you find is that the number of lamellae for that much width are much more in the layer than for the same width in the stroma above, which means the lamellae are thinner, but there are more of them. So it's more compact. Then the keratocyte distribution, have you ever stopped to think, how does air move in the stroma? You inject air and it goes here and there, and we say it will form the bubble or in the AC, but how is it moving? If you look carefully at histology of cornea that have been sectioned with air, most of the air moves through the spaces around the keratocytes. And there are none of these, potentially at least, or some have reported one or two, but I think they're the exceptions rather than the rule. So that's the second difference. More and more papers are showing that there are no keratocytes. So that is another way in which it is different. The proteoaminoglycans in it are likely to be different, but that's not been studied in greater detail. The elastin, that's the first real evidence of a biochemical difference in this layer compared to the rest of the cornea. And as I showed you with that band of elastin by immunohistology and by the on-face scanning electron microscopy done by a completely different group. So the differences are emerging. And as these differences come to light, people will begin to understand more and more that it is distinct, not just a part of the stroma. Even if it is a part of the stroma, like the Bowman's is, but is different enough to be called a different layer. But from the surgical point of view, the most important, it offers this plane of cleavage regularly. And whether you do it mechanically or do it with air or viscoelastic or whatever, and that is so important from the surgical anatomy point of view of all the procedures we do. And you see the evolution of PDEC and DALK and so forth. So to my mind, it has enough differences for it to be treated as a separate layer or separate part of the anatomy of the cornea.
Thank you for those lovely insights. Any further questions from the hall?
And one question, I just wanted to know how much the elastic tissue with the pre-Descemet changes with age. And is that one of the reasons why it's difficult to do a DMEC in a younger person and a PDEC, which is possible, but DMEC happens in an older person? And if the elastic tissue is changing, is it the reason why the unscrolling should be a little different in a PDEC, which has more elastic tissue compared to that of DMEC? Do you find any kind of difference that way?
So we haven't done a chronological study with age on the differences, but the accepted explanation, and there's another paper which is because we were restricted to pathology over here, I didn't bring all of that in, and of course would have taken a lot more time. If you look at the pre-Descemet's layer, it's like a rubber band. Lots of elastic, you pull it and it comes back, but it doesn't scroll. If you take a rubber band, you cut a length of it, do that, it'll come back, but it won't form a scroll. Because on the Descemet's membrane, it's on the top, and that part will then curl because clearly the elasticity will pull that part in. Now, if you take PDEC tissue, PDEC tissue hardly scrolls, very little. And if there's a grading of scroll, there is a grading, it's 1, 2, 3, 4. But this grading, when we published our paper on the scrolling characteristics, we added 0 because there's a grade 0 scrolling as well. And PDEC is got between 0 and 1 scrolling on its own. But when attached to the PDL, but PDEC tissue will be around 3. So all the scrolling of PDEC tissue is because of the Descemet's membrane. And then this is what we did very carefully, and you can do this. You separate the pre-Descemet's layer from the Descemet's membrane after you have quantified the scrolling of PDEC tissue, and you can separate the two. And then you'll keep them apart. And you see the Descemet's will scroll to grade 4, where the PDEC tissue will be less than the PDL will be less than PDEC tissue. So clearly, most of the scrolling is because of the Descemet's. Now, if you look at the Descemet's alone, with age it thickens. So if there's a thicker Descemet's membrane, more rigid, it will scroll less. And it may be, you're right, I think, that the elastase or the elastin layer also becomes thinner or weaker. And that is, again, another study to be done to prove some of these things and provide the evidence. Although, as a theory, this seems quite logical that there will be thickening of the Descemet's membrane and also a relaxing or a reduction in the elastin in the Descemet's membrane. So both those things are possible. We know, as I said earlier, the Descemet's membrane of a younger person is very thin. So it could also be the elastin is the same, but it rolls much more because it is thinner. But it could be there's more elastin as well, and then the two would make it even tighter, the roll. So it needs to be worked out.
Thank you, Professor Dua, for that wonderful talk and patiently listening to our questions and giving answers. I'm sure your questions, your answers would have created more questions in the minds of those who are listening, and people would work on these things like you have done, like you have taken corneal anatomy so much forward. And I'm sure your future findings will be taught to our postgraduates, and it will come into our textbooks sooner than later. Thank you, sir. And we already run out of time, but I couldn't stop because it is just too interesting. Anyway, thank you, sir, for accepting our request to come to KSOS. We hope you come to future editions as well. Maybe we could have you physically, maybe next year or the year after that. We'll work on that. Thank you, sir. Thank you very much. Thank you, Dr. Mallikarjun, Sridevi.
Thank you.
Dr. Arjun.
Thank you.
Bye.
Thank you.